I think we can already start po.
Lika muna. Okay, so can we start? Mr. Puna?
Yes po, Doc. We can start na po.
So there are some students leaving.
Doc, lumilipat po sila sa kabila, I think.
Okay. So you think they're all okay now?
Yes po, Doc.
Yes.
Yes po, Doc. We are tracking the attendance po. Isisend po namin kay Doc Prime.
So it's up to you now to give the attendance to Dr. Prime, okay?
Yes po, Doc.
So, what can you see? The entire screen?
Doc, the entire screen po.
The entire screen?
Yes po.
Okay, so... Okay, so we start, no? For today, I will be discussing with you the topic on the breast, okay? So if you have any questions, by the way, you can just interrupt me, no? Or you can just I can just entertain later on your questions after I finish my talk. This is just a very short lecture. Probably it will just take an hour or so. So you can just listen, and then what is important is you read on your books, your Principal Surgery by Schwartz, and if you have the Sabiston, you can also read on that. That's your Bible in surgery. Okay. So you see these pictures, no? These are examples of breast carcinoma. These are what you call the, if you see these features, they are the cardinal signs of malignancy. Okay? You will not be mistaken that this is malignant. So it's only the histopathology that will tell you perfectly that it is 100% carcinoma. But if you see this, by just looking only on the pictures, no, 99.9% you are dealing with carcinoma, because you see the features of the orange on the upper right corner, and then you have the fungating, ulcerating lesions in the lower picture, okay? And then on the other picture on the left, you can see a hard breast mass that if you do your physical examination, it is fixed to the chest wall. So actually, these are the cardinal signs. There are also findings of satellite nodules that you can see on the periphery of these breast masses, which also signifies a classical breast malignancy. So you will not be mistaken, no, if you will see this kind of breast features. So the breast actually is a very important organ, not only for us surgeons, but for everyone else. No, it is an asset for women. No, some women, if they don't have breast, no, they become very inferior, such that they would want their breast to be the best. Okay, but you see, there are some women who are gifted, and there are those who do not possess such good features. Okay, but usually, as we said, this is the favorite of all, especially men. Especially if you see this kind of breast, which I am sure is present among all the students listening to me right now. Okay, you must be smiling if you have this very good quality of breast, and you must be very, very lucky indeed. Okay, so the breast is a very important organ, as I've said, not only for men, of course, for the babies. It serves as good nutrition for the infants. I'm sure majority or almost all of you have undergone such states when you had your mother breastfed you when you were still young. Okay, so this breast really is a very important organ because it provides nutrition to the infants. Now let's take up a little of the anatomy of the breast. If you see this picture, you see that the breast is made up of your fatty tissues, your glandular tissues, as well as your ligaments that hold these structures, and it is fixed into your chest wall by your ribs, the muscles, your pectorals, and that makes it shape. Its blood supply comes primarily from the lateral thoracic artery coming from the axillary, your posterior intercostals coming from your thoracic aorta, okay, from the internal thoracic artery, and some of your anterior intercostals. So the same thing with your venous drainage corresponding to your arteries. So if you cut the breast, and you see the inside part, it's basically a mount where you see that it is fixed against the wall, which is your pectoralis muscle, against the chest wall, and there you have it. It is made up of your glandular tissues, your ducts, the Cooper's ligaments, which hold your glands in place. Then you have the draining excretory ducts converging into your nipple through your areola. Okay, nipple areolar complex. Now, the breast is divided into 4 basic quadrants. You have the upper outer, lower outer, upper inner, and your lower inner. Okay, correspondingly, if you see the clock, corresponds to your clock, 12 o'clock, and the most superior and the inferior is your 6 o'clock, and your right side is your 3, and your left side is your 9. Okay, so that this is a very important way to locate any palpable masses in the breast. So if you palpate a mass and it is located in the upper outer, so you would say so that it is in the upper outer quadrant of the breast, or correspondingly to the 9, 10, or 11 plaque positions. So this is how you will report a breast mass that is present in the patient. Okay. Now, this picture depicts to you, how important breast examination is to a woman. It is a must that all women should practice self-breast examination, because it is the only time, the earliest time that you will be revealing what is present in your breast. It is you, especially women, I am referring to, who would report that you have a problem with your breast, be it a lump or something coming out from the nipple, or a dimpling, or it could be changes in the color or the presence of thrush, or any changes that you see or palpate in the breast. So basically, self-breast examination should be done every month. So once a month. Do not examine your breast daily, because you will not be able to compare each day your problem with your breast, it should be done only once a week. And it is usually done 1 week after your period or your menses. That is the best time by which you will examine the breast. About 7 to 10 days after your period, that you will do your self breast examination. Your position, it can be lying flat, or it can be fronting a mirror. The best time is when you are taking a bath. When you are to take a bath, you want to take a look at your breast in front of a mirror, no? Looking at it in front, and then leaning forward, and then doing while you are in a side position. So these are the ways, the different positions by which you take a look at your breast. Okay, now if you do now your palpation, you should use the three middle parts, your second, third, and fourth fingers, and it should only be the tips of your fingers, not the entire palm of your hand. Okay? Then there are three ways by which you palpate. The grid method, as you can see it in the lower picture, examining it going down, going up, going down, going up, moving from one side to the other. Okay? The next way by which you examine or palpate the breast is what you call as a circular. Okay? From inside going outside in a circular manner. Okay? And then the third one is what you call as the clock method. 12 o'clock going from outer to inner, and then 1 o'clock, 3 o'clock, 5 o'clock, 7, 9, etc. until you have reached the entire clock, no? That you were able to palpate the whole part of your breast. Then you can do it on the other side, the same procedure. So this is very easy to do while you are taking a bath with the suds of your soap. No? So it is very slimy. So it is very easy to palpate even a small lump of less than 1 centimeter size or diameter. No, you will be able to palpate because it is slimy. But I urge you that you have to do it only once a month. Okay? Now, if you have an irregular period, you do not know when you will have your menses, no? It is advised that you choose a certain number in the calendar. So, for example, your birth date, then you can do it once during your birth date every month. Especially so for those who have irregular patterns. Okay? So this is how you will do your breast self-examination. And of course, if you find any abnormality or any change in your physical examination of your breast, then you have to seek consult with your doctor or your surgeon, and then your surgeon will do the important clinical breast examination. Okay? Now, once you go to the clinic, your doctor will do some tests which are very important in order to diagnose your case. No? Mammography is one of the mainstays, especially for those 40-year-old and above. Okay? But for younger individuals, less than 40 years old, a breast ultrasound is superior or better compared to your mammography. Why? Because you see, if you do your mammography in younger individuals, no, it would be very difficult to look for subtle masses. Why? Because you see the breast of young women, no, less than 40 years old are still very dense. So you see, because of its density, it will obscure any subtle masses that should be seen, no? And this could be seen and evaluated by your ultrasound. Now, if you have these modalities in your hand, then you now need to do your definitive diagnostic tool, which is your biopsy. Okay? Biopsy can be done in several ways. No? It can be a fine needle aspiration, where you make use of a very fine bore needle, say 23 or 21 gauge needle. No? And then what you get are just cells, and these are submitted to laboratory for analysis. The presence of malignant cells can be confirmed, no, by your pathologist. Okay? Another way and a better way to do your biopsy is your core needle biopsy. Your core needle biopsy can also be image guided or ultrasound guided, especially those that are small or less than 1 centimeter, that it is hardly palpable. No? Then it should be guided by your ultrasound. But of course, if it is really that big, 3 centimeter or 4 centimeter, then there is no need to do your ultrasound guide. Okay? So a core needle biopsy will give you a better picture and a better result, higher accuracy rate compared to your fine needle aspiration biopsy. Your small, no, non-pubble lesions can be detected by mammography, can be done by stereotactic means. Okay, then an open biopsy is important or can be done for those who would be requiring removal. So as you have mentioned, as you have learned in your minor surgery, your open biopsy can be in the form of an excision or an incision. Excision meaning you will remove the entire lump, okay? Whereas your incision biopsy is you just get a chunk, get a piece of tissue from the big tumor. So when do you do your excision and when do you do your incision biopsies? Excision if it is less than 3 centimeter or 4 centimeter, but if it is bigger than 4 centimeter, then a better way is just to get a sample or what you call as your incision biopsy. Okay? So this biopsy specimens, no, should be now given or transported to your pathologist for processing, and then a report of malignancy or benign conditions is expected. And then you will go after that. What will you do after taking your biopsy results? Another way by which a diagnostic modality is done is your MRI. No? A CT scan even so, but MRI is especially done for special cases like those, for example, who have difficult to interpret, no, mammography results, or those patients who have implants, for example. Okay, so this breast MRI is a very good diagnostic tool to diagnose malignancies. Okay, of course, on the other side is your ultrasound. No, so the radiologists have come up with a common way by which to report the results of their modalities, especially so your call this your Pirates report or your breast imaging reporting and data system. You will see this in all reports by the radiologist. So it ranges from 0 to 6. 0 meaning that it's an incomplete result. 1 if you see that the tumor is interpreted as negative, 2 as benign, 3 as probably benign, suspicious if it is 4, 5 is highly suggestive of malignancy, and 6 if there is already a proven malignancy by your histopathology. Important consideration here is 4, BI-RADS 4, wherein you have a suspicious lesion based on the characteristic features presented in your report. Okay? So if you have a BI-RADS 4, you will need to do a biopsy. So it needs biopsy for all those reports that are BI-RADS 4. Okay? Because the likelihood of cancer is now seen as more than 2%. Okay? 2% to 90% is much. So you need to do a biopsy for those suspicious lesions and as classified as BI-RADS 4. Of course, if it is 5 and it is already highly suggestive, it carries a likelihood of more than 95%. But this is still, you do your definitive biopsy in order to confirm that this is really a malignant condition. Now, here are the pictures of how the breast biopsies are done. Could be fine needle, could be a core, or a surgical open biopsy. Now, let's go now to the different benign conditions or malignant conditions, or what are the breast diseases that you oftentimes see. Breast diseases can be classified into benign and malignant. Those that are benign are subdivided into your non-proliferative, okay, your proliferative or your hyperplastic, okay, and then your hyperplastic with atypia, okay. So in this category, you have to be very, very what do you call this? Careful in identifying whether your breast mass is categorized as benign or malignant. So those under non-proliferative, like fibrocystic changes, cysts, okay, adenomas, are benign. They may be removed or observed. But if you have features like hyperplasia or those with atypia, there is a need to do biopsy in all cases because the chances of malignancy is present in these types of breast masses. Okay? However, on the other spectrum, you have the malignant side. You can classify this into different classifications like ductal, lobular, tubular, mucinous, papillary, metaplastic, and inflammatory carcinomas. Okay, so the most common breast cancer is your invasive ductal carcinomas, okay, which accounts for more than 60% of cases of malignancies. Okay, down the line are less seldom seen or less. They are not as common as your invasive ductal carcinomas. Okay. Now, benign conditions, that are very important to differentiate are your fibroadenomas and your fibrocystic changes. So you see in this slide the differences between the two. And these are very commonly seen among your patients when they come to the OPDs or in the emergency rooms, no, for consult. For those young individuals, most commonly their breast masses are fibroadenomas. No? Fibrocystic is more commonly seen among 35-year-old and above. In fibroadenoma, it is firm, round, and it is rubbery. Okay? Sometimes it is tender, especially so before or after the menses, because these are hormonal uh, changes. So they belong to your, they follow the cyclical changes of the breast. Okay? And on ultrasound, they may appear as dark area, homogeneous, round to oval with smooth edge bumps, comparing to your fibrocystic changes, which are usually they are tender, swollen, okay, lumpy, okay, ridge-like, okay, rugged, okay, and they belong to the cyclic stimulation of your menstrual cycle. Actually, these fibrocystic changes belong to the aberration of the normal developmental evolution of the breast. Okay, so that's how you differentiate the two. It's easier said than done, but primarily if you see this in very young individuals, and it is usually a fibroadenoma. Now, your fibrocystic changes can be seen in your histopath slides, your pathology slides as adenosis, fibrosis, or those with hyperplasia and metaplasia. Okay, or they have these dilated ducts. So these changes, belong to the spectrum of any form of aberration in the developmental involution of the breast. These fibrocystic changes are very common in women. Okay, they appear to be rugged, bumpy, and ill-defined borders, and they are usually tender. Okay, and you see that they may be non-proliferative or proliferative, with or without atypia. Okay, of concern are those that are hypoplastic with or without atypia, because they have the higher risk of the development of breast cancer, such that if you see patients that may be suspicious for malignancy, then it needs diagnostic modalities before you do your appropriate biopsy. Okay. Now, another important breast masses that you have to differentiate are your phylloides tumors and your fibroadenoma. Your phylloides tumors are similar to your fibroadenoma in all its features. Okay, the only very evident C that you can picture in this is the rapid growth. It's very fast. You see a breast mass that has been noted 6 months ago, then becomes more than 5 times or 10 times the size if you see it now. So that's phylloides. Unlike your fibroadenoma, which is very, very slowly growing. It's 1 centimeter 6 months ago. It may be 1 or 2 centimeters after 6 months. So it's really very slow compared to your phylloides tumors. And usually phylloides tumors are seen in elder age groups, 40 years and above. Whereas your fibroadenomas, they are in the younger bracket. Okay? Recurrence is very common in phylloides. That is why fibroadenoma is considered a surgical procedure such that to differentiate your phylloides from a fibroadenoma. Okay? The ultrasound may be the same. Okay, in cytology, you will see more cellular changes, and if you see malignancy, it is in the phylloides group. Phylloides is basically a benign condition, but there are a portion or small percentage that are also malignant. So you have also a malignant phylloides tumor. But basically, as I've said, these are benign phylloides tumors. But for fibroadenoma, this is relatively a benign condition. Now, more importantly is your breast cancer. Do you know that it is the most common malignancy in women? Breast cancer accounts for about 8, the lifetime risk. 1 out of 8 women will develop breast cancer in her lifetime. Okay? So, before, when I was still a resident, long time ago, it is 1 out of 15 or 1 out of 12. No? Then in the 90s, it has gone down to 1 out of 10. But beyond 2000s, it has now gone down to 1 out of 8 women will develop breast cancer in her lifetime. So the chances of this condition is really very alarming. That is why it is very important among all women to do breast examination of their breasts. Okay? Because you see, breast cancer is relatively curable condition. Unlike other breast cancers, once they are diagnosed late. Here, breast cancer can be diagnosed at its earliest stage. Why? Because it is palpable. Okay? Unlike malignancies in the GI tract, before you develop symptoms, they are already in an advanced stage. Okay? In breast cancer, you can detect or diagnose a stage 1 tumor. Okay? It's second to lung as to the cause of cancer in all. No? And it can be spread, and it can be still an in situ, meaning in place. If it is in situ, no, it is not yet cancerous, but it is in situ. Once it becomes, it spreads, becomes invasive, no, or infiltrating. The actual pathophysiology of breast cancer is an interaction between environmental and genetic factors. Okay? 90% is due to genetic causes resulting from aging process, the wear and tear of life in general. Of course, we do not know yet the exact etiology of breast cancers, but there are a lot of risk factors that have been related to or why the patient would develop such, and they have already listed a lot of possibilities or risks in those that are having this. So you see this slide tells you that age group, those 40 years old and above, do have a higher risk of developing breast cancer. So if you see breast masses in those 40 years old and above, it is always a possibility that this is malignancy. Although I'm not saying it is 100%, but the risk is very high, especially so if there are other features of malignancy. So if you see a breast mass in the young, less than 30 years old, chances of malignancy is not very high. But mind you, I have a patient, an 18-year-old, way back 20 years ago, who had breast cancer. So it is now becoming, it is now seen even in the young age groups. Okay, but rarely, no, you see most of these in those age groups, 35 or 40 above, especially 50-year-old above. Then one of your considerations really is a malignancy. Reproductive risk factors, those that have early menarche before 11 years old. I'm sure majority of you have the menarche at these age groups, 11, 12, 13. That is the usual age groups of your first menses. But those with menstruation at early 8, 9, 10, then they are really at a very high risk of developing breast cancer in the future. And those with late menopause, those who have been menstruating until age 54 or even 55, no, then they are considered risk factors. Or those who do not have children, okay, or those having children more than 40 years as their first child, they are at risk in the development of breast cancer. Why? Because of the prolonged exposure of your body in hormones, especially your estrogen. Okay? You know that breast has a relation with your uh, high levels of your hormone, estrogen. Okay? Then, lifestyle factors, those that are that take a lot too much of saturated fat. Those who are fond of eating what we call this French fries, no? Those that this do you know that this French fries, no? There are those that have been cooked in several heated oil, and then this is very risky. I tell you, okay. Those that are obese and those people or women who are very addicted to alcohol, meaning they take a lot of alcoholic beverages, then it increases the risk in the development of breast cancer. Also, those who have been taking oral contraceptives for several years, or those who are having hormone replacement therapy after cessation of their menses. Okay, they are also prone to the development of breast cancer. So it is also hormonal in nature. Radiation, and of course your family history. No, you see the relative risk of more than 2 per 2. Okay, especially those with first degree relatives, those who have mothers, those who have sisters, those who have first degree relatives, they are at a high risk of developing breast cancer. But usually, you say, I mean, in my uh, career, no, I have seen patients with breast cancer, 75% of them do not have really breast cancer in the family. So you see, even without family history, no, they have a high degree of the developing of having breast cancer, even in a negative family history. So you see, there are a lot of patients who would come, and if you ask them if they have family history of breast cancer or ovarian cancer, they would say no. But uh, can be told, no, they are diagnosed with breast cancer. Okay, so this is just a repetition of the different breast risk factors. Now, what do you see in breast cancer? What are the features? You see a breast lump? No, it should be a breast lump that is hard, irregular, less tender. Okay, it can be fixed. So this is the breast lump that we usually have in breast cancer. Some women with retracted nipples. or inverted nipples have possibility of having breast cancer. But I am not telling you all. You see, breast retraction, nipple retraction is not really a cardinal sign. There are a lot of women who have retracted nipples or inverted nipples, but they are not breast cancer. Okay, but if you have a mass from the beyond or beneath your nipple, and then your nipple is retracted, then that is a possibility. Okay, nipple discharge actually it's not a cardinal sign. Likewise, there are those who have nipple discharges like serous discharges, but they are not benign, they are not cancerous. They are mostly benign, especially so your intraductal papilloma, which is the most common cause of nipple discharges, in females. But if you have a nipple discharge that is bloody, no, then that is a consideration that you can be having breast carcinoma. There are excoriations in the skin. Okay, the skin changes. This may also be a manifestation of breast cancer. But you see, you can also find this in infections. We can have dermatitis, but these are benign. Then increased volume of the breast, actually not so. But if you have a breast that is asymmetric and it is really large, and also with other features like inflammatory conditions, then that is also a feature of malignancy. Breast and nipple pain, well, not so. Redness of the skin, sometimes if you scratch it, it's not cancer really. But if there are changes, if there are reddening of the skin associated with satellite nodules, then it may be a feature of your breast cancer. Thickening of the skin, like your pudorans or your orange peel skin, is really a cardinal sign of malignancy. If you see this, 99% chances you have breast malignancy. Okay, dimpling is not a feature, but it can also be seen. No? I mean, it's not 100% sure that you have breast cancer. There are instances like infections, fat necrosis, then you can have dimpling also. The dimpling in your breast cancer is brought about by the pulling of your Cooper's ligament. Especially so if the patient leans down, you would see that the skin is retracted, meaning it forms a dimple. Then this could be due to the pulling of your Cooper's ligament. So this is a malignant condition. Okay, presence of axillary masses or lymph nodes that are palpable, uh, associated with course with a breast mass, then you may have a possibility of breast cancer. But there are also axillary masses or lumps that are benign, especially so if there is an infection going on nearby, okay, in the near areas. Okay, so suffice to say that if you see patients with fungating, ulcerating breast lesions, or pudorans, or inflammatory condition of the skin, or a lump that is fixed, hard, stony hard, then those are the features or cardinal features of your malignancy. Now, in your breast examination, you can see a lump, or it could be a retracted nipple or a dimple, or there could be dripping sanguinous fluid, okay, or rashes that are uh, different from a benign condition or any changes, then there is a need to investigate further. Now, if you have already a biopsy of the breast mass, turning out to be malignant, then it is very important to stage your patient's breast cancer. And this is in the form of your Pnm classification or uh, uh, staging. No? P is for your tumor size, N is for the presence of node, axillary nodes, and M if there is already a distant involvement of any organ. So you call that your metastasis. Okay? Combinations of this will give you a staging, stage 1, 2, 3, and 4. Okay? So you can read this actually in your books, no? And it is specifically uh, classified there. So this is what I'm telling you a while ago, no, regarding your Pnm classification, where you have a T1 that is up to 2 centimeters. Then if it's now 2 to 5 centimeters, it is T2. And more than 5 centimeters is T3. Okay, but if it is 2E4, it means that it has broken through the skin, meaning there is ulceration, fungating, lesion, or there is already an attachment to the chest wall. Okay, for lymph node status, it can be 1, 2, or 3, or NO, meaning there's nothing that you can palpate. Now, if you palpate for a swollen node, but it is not matted, then it is N1. But if it is bumpy, swollen, lumpy, meaning there are a lot of nodes that you will be that you can palpate, then it is N2. Okay, and N3 is more what we call converged lymph nodes. No, they are the plenty, palpable, enlarged lymph nodes. Then you have the N3. M0, there is no metastasis, and M1 is already we have an involvement of any adjacent organs. So this is just your classification of your breast cancer from early stage 1. Stage 1 is less than 2 centimeters. There is no involvement of your node or there is no metastasis. Stage 2, if it is already 2 to 5 centimeter, there may be N1. Okay? Stage 3, if it is 5 centimeters or more histosize, or it could be N2, and then, or N3, and then stage 4 is any size for that matter, as long as there is metastasis, then it is already stage 4. Now, let's go to the important aspect, which is how breast cancer is treated. No? It is treated by surgery being the mainstay, radiation, hormones or hormonal treatment, chemotherapy, or a targeted therapy. So these are the 5 ways by which you treat breast cancer. Depending on the characteristic features or the behavior of the tumor, and also the classification as to the stage and involvement of the estrogen receptor status or involvement of the HER2 or the involvement of the nodes. So it depends on what you will be giving to your patient. So it is not a one procedure treatment for breast cancer. It is individualized depending on the patient's condition, depending on the patient's capacity to pay, depending on the surgeon's and the oncologist's view on how to treat breast cancer. Okay? So suffice to say that for local treatment, it can be surgery or radiation, meaning the treatment is just localized to the breast. Meaning, if you do the removal of the mass, you call that lumpectomy, or you remove the breast, simple or a radical procedure. What's the difference between a simple and radical? Simple meaning you just remove the breast, retaining your pectoralis muscles. In radical, no, this can involve the pectoral muscles as well as the lymph nodes. So there is even more radical removing the chest wall and some ribs. Okay, so you call that the urban procedure. Actually, you can read this in your books, no? The different procedures. Pate, Hagensen, you can have your Hashing clause, and you have your urban. So there are so many ways. We cannot give you in detail. This may be for the resident level. Okay. Now, with your radiation treatment, it can be an external beam or your internal. No, you can have your LINAC, other ways by which you do your radiation treatment. So the same thing. This is a local treatment, meaning it is just focused on the breast and its adjoining surrounding areas. Okay. Now, if it has involved any single lymph node, then it is already considered a systemic condition, meaning the chances of spread into the various uh, organs or system is possible. That is why the mainstay is your chemo, which is systemic, your hormone treatment, and your targeted treatment. So these are all considered systemic form of treatment. Okay. When you say chemo, no, you will be giving your patient indication is there is uh, already an involvement of the lymph nodes, and also other indications are the tumors are aggressive. The tumor is so aggressive based on histopathologic pictures. Okay, then a chemotherapy is advisable. Of course, there are so many ways by which you give your chemo and what particular chemo drugs is specific for your patients, depending now uh, is dependent on your oncologist what form of chemotherapeutic drug should be given to your patient. So it is tailor-made individually. It is not a chemo for all. No, it should be tailored to each individual. Hormonal therapy is given if you have an estrogen receptor, ER positive, or progesterone receptor positive result in your examination, meaning the tumor is examined, no, for the presence of estrogen receptors. The tumor is submitted to the histopathology and then subjected to examination of your estrogen receptors. If there is a positive estrogen receptor, then your hormone treatment is given. Your hormone treatment, there are a lot, no? You will probably read that in your books if you are if you want to go deeper on understanding hormonal treatment. No? These are anti-estrogens. So these anti-estrogens will attach to that estrogen receptor, and then it will slowly kill the tumor itself. Okay. How about this targeted therapy? If the HER2 receptor is present, it means that the tumor is aggressive. So if you are HER2 positive, then there is a need to give your targeted treatment. in the form of your trastuzumabs, pertuzumabs, etc. However, this is very expensive, and there are only a few patients who can afford. So it is very expensive, especially so 2, 3, 5 years ago. But nowadays, it has gone down to less than 50,000 per cycle, per giving, and you give it every 21 days for 1 year. So it is still very expensive. There are only very few who could afford this. So much so that for patients, no, who could not afford, no, and they need targeted treatment, they have you can bring or you can send your patients to charitable hospitals, charity hospitals, where I think they get some they get also some medicines from your PCHO, etc. No, but if you do not have this form of treatment, the chances of recurrence is very high, especially so if you have HER2-positive tumor. Okay? So in summary, no, these are the different modalities or treatments that you give to your patients. It is local and systemic, depending on the need of the patient. It is tailor-made depending on that individual's behavior of the tumor. So in surgery, no, what are the different surgical procedures done to the patient? Breast conservation treatment. This is a removal of the tumor. It's a wide excision, meaning it's not only the tumor that is being removed, but a 1 or 2 centimeter around in the periphery of the tumor is removed. This is basically indicated for early stage tumors. Stage 1, 2, or 3, early. There is still early breast cancer. As long as there is no involvement of the lymph node, there is no nodal involvement, then you can still classify this as early breast cancer. And for some women who do want to preserve their breast, no, this is a nice procedure. So especially in the Western countries where the breast is their asset, no? They do not want to have their breast removed. So for early breast cases, early breast cancer cases, this is what we call as the BCT or the breast conservation treatment. However, there is a need to give radiotherapy as an added treatment for these cases. So it is a quadrantectomy or a wide excision plus radiotherapy. So that is the basic mainstay of your breast conservation treatment. Okay? If you just remove the tumor without follow-up radiation, then the chances of recurrence is very high. Sometimes it is very difficult to explain to the patient that they would just want their breast to be removed if it is indicated. They do not mind anymore having only one breast, especially among Filipinos. No? If they have breast cancer and you leave their breast as a conservative treatment, but you have to explain to them that there is a higher chance of recurrence compared to those that where the entire breast is removed. So some or even more patients, more than 60% of patients will just have their breast removed. So how is this done? It can be a total mastectomy or an MRM or a modified radical mastectomy. So if it were total mastectomy, they will remove the entire breast, some pectoral muscles, or the axillary lymph nodes. Now, before, no, the radical procedures entail the removal not only of the breast pectoralis muscles and in the axillary nodes, they have modified now into retaining your pectoral muscles. Okay, so this is Hatching clause, procedure where you remove only the breast and axillary nodes. And they have found that there is no significant difference doing your radical mastectomy versus your modified radical mastectomy, such that the mainstay now is forgetting the radical mastectomy. Rather, you go on now with the modified radical mastectomy. Okay? For some, no, who would advocate breast conservation treatment, then it is very important to do a sentinel node biopsy so that if you find this negative, no need to give your chemotherapy. But if there is a positive lymph node, and that is your first node, is your sentinel node that is first affected in the series of axillary lymph node involvement. No? If that is positive, then the chance of positivity in the others are very high. So you have now to do your axillary lymph node dissection. Now, some women would want their breast to be reconstructed after surgery. Then there are a lot of practice plastic surgeons available. Then they can do and opt to do to reconstruct their breast. It can be in the use of the rectus muscle as your Trump procedure, or you can have your silicone gel as an implant, no, to form the mound of your breast. So it can be an early or it can be a late reconstructive procedure. Okay? So when is mastectomy indicated? For those who are already 4 centimeter or above, okay, but for those less than 4 centimeter, then a breast conservative surgery can be done. Okay, but you have to be very careful that it is not a multicentric feature and it is located in the periphery, such that you can do your breast conservation treatment. No? But if you are defied, no, if it is near the nipple, for example, then it is advised that a mastectomy is to be done. Now, what is this adjuvant treatment? When you say adjuvant treatment is another form of treatment, especially those after surgery that you need a follow-up treatment for those with lymph node involvement. Chemo or your herceptin or your targeted treatment or your hormonal can be given. Okay, so it is highly what we call this difficult to understand at your level. So I will leave it to your readings. Now, this is just a summary on how to do and manage breast cancer. It is multidisciplinary. It requires convergence and discussions among surgeons, radiotherapists, oncologists, your pathologists, your other professionals, your nurses is involved, and how to take care of a woman with breast cancer. So you treat the woman with breast cancer in totality. Okay, do not just be centered on the tumor. No, you have to also consider what is the mental status, psychological status of your patient. So the treatment involves not only doing removal of the tumor and giving your chemotherapy, etc., etc. You also have to involve other disciplines like your counselors as well as nurses who will take care of their patient and even the family, of course. Last month is the Breast Cancer Awareness Month. So I'm sure all of you are very familiar with this insignia. No, this is every October month. Well, we celebrate October Breast Cancer Month. So We always ask women to be very vigilant in their breast by doing breast self-examination, and then going to their doctors if there is a need to do so, especially if there is any form of changes that we see in their breasts. Okay, we can fight breast cancer, especially so if it is seen at an early stage. But do not be worried, even in late stages, there are a lot of different modalities of treatment of breast cancer. Even stage 4 breast cancer, no, they remain very happy with these forms of treatment, and they still associate themselves with society. Okay, so in summary, I have already presented to you the importance of the breast and the findings of any abnormality in the breast. That you have to be very, very important. You have to take care of your breast because this is uh, very important organ that nourishes your infants. When you become mothers in the future, no, you have to take care of your breast because you will help your child grow with the nutrition that you will provide him or her. Okay, so the breast is very important not only for children but even the partners. No, you have to be also considerate that the breast is also very important to other people. Okay, so the breast I have mentioned is very significantly important. From east to west, breast is the best. Thank you very much for listening. I am sure you are smiling in your own ways now as you see that the breast is a very important subject matter. So thank you. So this ends my lecture. I do hope that you learned something in this lecture and hope to see you when you go to your face to face with your professors, and hope to see you again uh, in your clerkship. Okay? If there are questions, okay, you can ask me. Okay. How shall I go now? There. Do you have any questions?
Doc, question po.
Yes.
Doc, how rare is it to encounter breast cancer in males?
Oh, it's relatively rare, but you can see also breast cancer in males. No? In my more than 20 years of practice, I have seen probably about 5 to 10 cases of breast cancer in the males. Treatment is the same. Features are the same. Okay, there is no difference with women on how to diagnose it, on how to treat it. It's the same. But you see, it is relatively rare, not as common as women. Okay, why? Because they have lesser estrogen. Okay, estrogen is the factor that usually uh, is associated with your breast cancer. The more exposure to your estrogens. Okay, but you see this also in males. So you have also to examine your breast among males. No, if there is a small lump that you see, then there is a need to do and diagnose it very well. Then, if it turns out to be carcinoma, then you have to subject this to appropriate management and treatment. So the same modalities, the same treatment, there's no difference actually. Okay? Any other question? Okay? So I see a lot of beautiful faces here. I do hope you do take care of your breast because you're still young. No, you're still young and vibrant. So even in the young, as I have said, no, you can still you still also develop breast malignancy. So be very, very attentive and be very careful. Any other? It's 6:30 or 20. If there is no more, so I hope to see you face to face in the future. Hopefully by January, you'll be going to your schools and your teachers. Okay? Good luck. I am leaving now. Thank you for listening.
Thank you po, Doc.
Okay.